introduction, but I will still provide one. So, Dr. Montaner is the chair of AIDS research and the head of the division of AIDS at University of British Columbia. He's also the director of the Center for Excellence in HIV/AIDS. He's the president currently of the International AIDS Society, and he's also a member of various scientific committees that involve decisions around HIV therapy. He's also one of the co-founding directors of the Canadian HIV Treatment Network. He's supported by a background in internal medicine, and he's a national and international leader in HIV/AIDS clinical work as well as research. He's published over 300 refereed journal articles in high-impact journals that have influenced policy as well as practice in HIV/AIDS. His 5 most significant areas will be around the prevention and treatment of pneumocystis carinii pneumonia, adherence to highly active anti-retroviral therapy, HIV treatment failures, HIV treatment simplification, and also emerging anti-retroviral toxicities. So Dr. Montaner, as all of you know, has been a pioneer in the field of HIV/AIDS, and I suspect will continue to be a world leader. And he has a very bold new revolutionary initiative. This strategy is called Stop HIV/AIDS, and we all think it'll propel Canada into the forefront in treatment and management of HIV/AIDS and the response that we need to have on a global level. So also interestingly, the Globe and Mail has recently made a list of 7 cool people and issues, and he named Dr. Montaner the newspaper named Dr. Montaner as one of them. So I feel very fortunate to have him as a colleague, and also we should be very grateful that he came to speak to us tonight and to share his ideas and his vision. Thank you.
Thank you very much. Thank you, Anita. I had to tell you the truth. My children still take issue with the Globe and Mail ranking for the coolest things in Canada. So I'll work on that aspect of my curriculum. I apologize. I'm standing up here because my screen somehow is not showing me the full picture, so you'll get a lateral view of me tonight. What I want to do today is give you a bit of an updated overview of some of the work that we're doing at the center. And since I recognize a number of faces here that I have put through this torture before, I'll reassure you there is some new material here that hopefully you will find interesting. The story, I thought there was a bit, the story starts really when my good friend François Barré-Sinoussi, who actually was visiting with us a few months ago in the month of November, discovered HIV as the cause of AIDS. For quite some time earlier on, there was some hesitation as to what was the real mechanism that led to the immune deficiency related to the acquired immunodeficiency syndrome. But her discovery in 1983-84 of this virus basically settled that issue for most of us. I do realize that there is some discussion lingering in certain circles, but the data that I'm going to show you next, I think, is going to convince you quite nicely that this issue in our minds is settled. François discovered the virus a mere 3 years after acquired immunodeficiency syndrome, AIDS, was first discovered. Most people don't realize that. This is quite a remarkable achievement in such a short period of time. She was working at that time in the laboratory of Julio Montaner in the Pasteur Institute, and for this discovery, she received the Nobel Prize in Physiology and Medicine in the year 2008, which is something that makes us very proud. From 1984 to 1996, we went on to what you could consider a bit of the dark era of anti-retroviral therapy. We knew what causes HIV. We had some treatments that we were working with, but as many of you may remember, the effectiveness of those treatments was a little bit of a problem. We could only achieve partial responses. They were transient. They were not lasting. And so because the drugs were not very well tolerated, the treatment in those days was regarded as controversial. Some of us, we didn't give up, and we started experimenting with various approaches. And I'm quite proud of the fact that around 1994, we convinced a number of companies that had drugs that were at that time being used for HIV to do what it was a bit of a crazy experiment of mixing these 3 particular drugs together That's an experiment that we started in 1994, and unbeknownst to us, by 1995, December 1995 to be precise, we had data for the first time that showed, to our surprise, because we were not expecting this, that with triple drug therapy we could actually block the ability of the virus to replicate. It was interesting because we learned that before we knew what the impact of stopping the ability of the virus to replicate would be. But nonetheless, that led us to Vancouver 1986, which some of you may remember. It was the International AIDS Conference that we hosted here in Vancouver. In 1994, this is Joe Average's painting, we crafted the image for the conference. That was Joe's work, based on the logo for the conference, One World, One Hope. We truly didn't know there was a hope. We were hoping there was a hope. Little did we know that by 1996, the hope was going to emerge from our own clinical trials. A separate clinical trial was being done, unbeknownst to us, in the United States, using a different approach, also triple therapy. And by the end of the conference, we were able to put all of that together and crafted a new therapeutic approach, the so-called highly active anti-retroviral therapy, to which we often refer as HAART, H-A-A-R-T. In those days, they used to be referred to the cocktail in sort of a colloquial kind of way. We were in a unique position because we had these results available to us by December the prior year. So by the late spring, early summer of 1996, we were in a position to convince the government to allow us to move forward as the first jurisdiction in the world to embrace highly active antiretroviral therapy for the people of British Columbia. And so very quickly, by 1997, we had been able to show, 97, 98, that death rates among those individuals who were engaged on antiretroviral therapy in the province of British Columbia had decreased by 85%. We never seen something like that. And not only we never did see something like this before, we saw for the first time that these trends were sustained. And still today, the impact of antiretroviral therapy in our midst remains the same, as I'll show you in a moment. As a result of the use of antiretroviral therapy, as I described, we also saw a rather significant improvement on the life expectancy of people treated with HIV. Now, I often tell people that these figures are basically a work in progress because, as many of you will recognize, the first generation of individuals who are infected with HIV, who are being treated with truly modern treatment, where we think we know what we're doing, is actually only been treated for about a decade. So prior to that, we were victims of having used suboptimal therapies in the early days, and therefore we anticipate that the expectancy, the life expectancy of people treated with truly modern treatment based on the current understanding of how to best use the drugs and the laboratory is going to be actually much better. Having said that, a lot of my patients who started treatment early would not be alive today, and in fact, with the newer drugs, I begin to believe that we have reset the clock for them pretty much as if today they were to belong to the new generation of treated patients. This is a paper that actually just came out January 1st of this year, and I wanted to show it to you because it continues to show the gains that we're making regarding the treatment of HIV day after day after day. This is data from the province of British Columbia, where we report the improved virological outcomes in the province, which are concomitant with decreased incidence of HIV resistance. When the treatment, with HIV treatment fails, virological, either because it's not effective or is not taken properly or is not taken with the regularity that is required, meaning every day and so on and so forth, the virus, which is always there, will come back, will rebound, and in the process of doing that, oftentimes will become resistant to the medications that the patient is taking. And so it is important to know that as we're treating more people and more effectively, we're also not seeing more resistance in our community. And this is what we concluded in this paper here. Now, I won't read you the abstract because it's quite boring. I'll show you the data. This is Richard Harrigan's slide that shows increasing number of people treated in the province of British Columbia, and I will show you more of this in a moment. So you see here, we've gone, this is cumulative exposure to antiretroviral therapy. Don't need to worry about the particular units here. Basically, this is 2,500 people treated in 1999 to 2004, and then we liberalized the treatment and we increased from 2,500 to 5,000, and that gives this kind of exposure here. But the important thing that you see here is that resistance, the bad resistance that develops when people cannot tolerate or cannot take the treatment properly, has been dropping rather dramatically. This means that the treatment is working very well. And as you can see here, and this is for those of you that are data-driven, what you see is that the incidence of resistance using a logarithmic scale here has been dropping actually steadily in what it would be a downhill slope, which we predict that at this rate, pretty soon we're not going to see any if people continue to behave the way they are doing with regards to their ability to tolerate and take the treatment. And why is that? Well, the reason for that is very clear, is that our treatments, as they became better understood, better accepted, better tolerated, more compact, simpler to take, and so on and so forth, allowed patients treated with antiretroviral therapy to suppress the ability of the virus to multiply better and better and better and better every year. So from 2000 to 2007, 2008, you see that we are now operating at approximately 80% suppression rates, and this line yet has to show a lack of desire to continue to grow, and we'll do whatever we can to continue to push it, and certainly our patients are doing their best to ensure that we push that through the roof. Now, you might say, well, Julio, good, that's maybe happening everywhere around the world. And I wanted to show you some data to put things into perspective, because often we fail to acknowledge the fact that in the environment where we live, we have opportunities to benefit from certain programs in ways that other people, they don't. So let's go to San Francisco now. This is a paper published in Science. It was published January 14th, 2010. So this is very recent data. What it says here is that basically evolutionary dynamics of complex networks of HIV drug-resistant strains is taking place in San Francisco. Let me just translate that in a language that we all understand. What Sally Blower is saying here is that over the past 2 decades, HIV resistance to antiretroviral therapy has risen to high levels in wealthier countries of the world, however, not in Canada. And they are concerned that the new wave of antiretroviral therapy resistance that they are seeing in the United States will become a significant threat to global public health. Now, I beg to differ. This makes Mr. Obama very unhappy, makes me very unhappy too. I think Mr. Obama is very happy with our data. And I think that this is something that is being missed. We not only have access to better treatment, better strategies, better support, but altogether to a better health system that I truly believe represents the backbone of the success that we're seeing in our antiretroviral therapies. And I wish our friends down south would listen to this, because the politics down there are changing rapidly in a kind of nasty way that may interfere with their ability to move forward a healthcare agenda that I think it would be very important for our neighbors down south. Now, I think this is all I'm going to tell you about the success of therapy. It suffices to say that antiretroviral therapy is working extremely well among those that are accessing treatment. And the problem today, and I'm not going to expand on that, is that we have, but I'd be happy to take questions if you want, is that we have segments of the population who are infected with HIV that either they are not aware that are HIV infected, and we need to do more to identify those individuals to help them to access HIV testing, or if they are aware that are HIV infected, they are dealing with other life challenges, whether it's mental health or addictions or homelessness or poverty or the like, that preclude them from making HIV a priority. And unless we help them find their way around the system so that this becomes a priority for them, their health is going to be compromised, and also our ability to contain the epidemic will be compromised. So together we need to do something to address those issues. That's part of the reason why we are so much involved in initiatives such as the supervised injection site that allow us to meet addicts where they are at, so that we can bring health care to them as opposed to expecting that they will find their route to the health care, which is often impossible. But that's another subject, another story, and we'll probably have to have another meeting for that. What I wanted to really tell you now is the second part of the work that we're trying to do, which relates to the fact that we believe, in fact we now know, that highly active anti-retroviral therapy, HAART, can actually reduce HIV transmission, in addition of preventing death, decreasing morbidity, and keeping people healthy living with HIV for a very long time. So what we have learned over the last while is that HAART stops HIV replication. And when I discuss this subject with my colleagues, students, and the like, I usually like to stop here and ask people the question, how soon do you think that treatment can stop HIV replication? And they look at me and they don't say anything, of course. And so I say, well, what do you think? It takes a year, it takes 6 months, it takes a month, it takes a week, it takes a day, it takes a minute. And it's interesting because I get answers for all of those values. And the reality is that HIV treatment stops viral replication after your first dose. The first day you start antiretroviral therapy, you shut down viral replication. Following that, after the virus stops making viruses, that is, what you have is a period of time that it takes for the virus that is already made and is circulating in your blood to be cleared from the blood. And that's a mathematical function. That's the time that it takes to clean the streets when they're dirty. The more garbage you have, the more it takes to clean them. Well, you shut down viral replication, and then what happens is that depending how much virus you have in the blood, it will take a longer period of time to decrease the amount of virus. And actually, it's a mathematical function. It takes 1 month to clear 90% of the virus that is present in your blood. And that's very convenient because 90% is like subtracting a zero from any number, meaning that, so if you have a very large amount of virus in your blood, say 1 million copies of virus per milliliter of plasma, that would be a high concentration of virus, it takes 1 month to get 90%, another month to get the other 90%, and another month to get another 90%, so I now subtracted 3 zeros, another 3 months to get another 3 zeros, so you're down to 1 copy of virus per milliliter of plasma after 6 months. So you don't need a PhD to figure out how long it takes to get rid of the virus. Within 6 months, give or take, it could be 5, it could be 9, it doesn't matter, but within the first 6 to 9 months, that person should have an undetectable viral load, meaning that we cannot actually quantify virus in the blood of that person. What that means is that because we shut down the viral replication, there is no more damage imposed on your immune system. We measure your immune status by measuring the so-called CD4 cells. Those are the immune cells that are basically the targets of HIV damage, if you want. And so the higher your CD4s, the better off you are. The lower your CD4s, the worse off you are. A normal CD4 is between 400 and 1400. People with HIV, they often have very low CD4s. They tend to get sick below 200 CD4s. Their life is in danger, imminent danger, once they are below 50 CD4s. Of course, things can go wrong sooner, but when you see somebody with less than 50 CD4s, you get really, really nervous. Things are really looking problematic. And why am I telling you all of that? Well, because we want to keep people healthy. We want to bring their immunity up right away. And so what happens is when you shut down viral replication, the immunity goes up immediately. It doesn't wait until your virus is clear. But for you to have a long and sustained response, the virus has to go down to undetectable levels. So after those 6 months, if you had 1 million copies of viral load. And then what happens is that the virus goes into some sort of sleepy state in remission. No further virus is being made. And subsequent to the virus being cleared from the blood, you have that the virus is also being cleared from other reservoirs, namely tissues or body fluids. So you stop replication, the virus levels fall to undetectable, first in the blood and then in sexual fluids, actually also in tissues, rectal mucosa, for example, the brain, the lungs, the livers, etc. And when that happens, we would like to argue that because you now have no virus to be detected, there should be a sharp reduction in HIV transmission. Did I say no transmission? No, I didn't. I said sharp reduction, because if you try hard enough, transmission may occur. And there are always individuals who may not clear all of the virus all of the time, so you have to be very concerned about that. So we do not recommend that people abandon safer sex practices or safer injecting practices, but we do recognize that from a public health standpoint, you take somebody who has 1 million copies of virus per milliliter. You know how much a milliliter is, by the way? A milliliter is about this much. So we're talking about 1 million copies of virus per milliliter of plasma. Think about this for a moment. You have 5 liters of blood inside your body. A milliliter is like this. Now make that 5 liters. So it's a lot of virus. And that's only in the blood. So from 1 million copies, we are able to bring you down to undetectable levels. If that is in the blood, and it's happening also in the semen or in the vaginal fluid or the rectal mucosa, then you expect that the likelihood of HIV transmission will decrease rather dramatically. We had an opportunity to outline this thinking in fairly detailed way in a paper that we put forward in The Lancet in 2006 that was eventually a plenary at the International AIDS Conference, at the time considered a bit controversial, but since then has become pretty much mainstream. And I wanted to take this opportunity to acknowledge my colleague Bob Hogg from Simon Fraser, Evan Wood, Thomas Kerr, Mark Tyndall, and Richard Harrigan from UBC, and Adrian Levy from Dalhousie at the present time, who work on this work with us. Since then, Viviani Diaz-Lima and a number of others have contributed greatly to this work. But before I go forward with that thinking any further, I think I need to emphasize, I said it once, but I'm going to say it again, this is not about replacing what is known to be effective in terms of prevention, namely education, changing behavior, and harm reduction, with treatments. We don't want to medicalize prevention because that's not necessarily the best way forward. And these things actually are good not just for HIV, but a whole bunch of other things. They are easy, they are inexpensive, they are available at all times. You don't have to remember a whole lot to know how to do all of this stuff. And actually, it's very good for society at large. So we want people to enhance these kind of behaviors. We, of course, look forward to new strategies, whether it's circumcision, female condoms, microbicides, or other new technologies. And someday in the future, when they become available, vaccines, if they can be fully prevented. Unfortunately, as somebody recently said, vaccine is the only thing that has remained the same throughout the history of HIV. It was going to be available in 5 years when we first described HIV, and it's going to be available in 5 years till today. It's the longest 5 years we've ever seen. So don't count on it. I predict that we will not have a vaccine that is going to be adequate for, say, our children, probably until the next generation. And that doesn't mean that we will have it at that time. It's just that at the state that we are today with regards to the knowledge in this area, unfortunately, there is way too much work to do before we can get to an effective vaccine. So we need to do something to improve on the performance of these strategies using what we have available today, because, quite clearly, HIV continues to grow, despite the fact that these things are available, whether it is because we are not doing a good job at applying these techniques to the best of our abilities, or because they have reached a ceiling that will vary from one place to the other. But at the end of the day, we need to do something, because the number of HIV-infected people, whether it's here or in the rest of the world, continue to grow. So, you would like to ask me at this point, well, stop all of that nonsense and just tell me, is there any evidence that HAART can stop HIV transmission. And I'll say yes, in humans. And this is the evidence. In fact, the evidence has been present, staring at us on our face for the best part of the last decade or two, more than 2 decades. And I'll show you here what we've seen when it comes to maternal to fetal or to children transmission of HIV, starting in 1990 in Canada. You see here in light blue the number of women infected with HIV that went on to become pregnant, and this dark blue shows you the number of children born to these mothers that were HIV positive at birth. 50% in 1990, 50% in 1991, about 50% in 1992, maybe 40% in 93, maybe make it 30%, 30%, 30%. A slight increase in the number of women infected with HIV becoming pregnant, and not much of a change with regards to the percentage. The percentage decreased slightly earlier on because we employed better obstetric techniques that prevented some of the late blood transfusion from the mother to the child. But in reality, it didn't get any better than 30% by 1996. And then, voila, 97, 98, 99, 2000, increasing number of women becoming pregnant with HIV and decreasing number of infants being born with HIV. And the reason for that, if you remember 1996, that's an important day to remember, is that here we came up with a so-called cocktail. And really, we were not planning it this way. But as women that were infected with HIV started taking anti-retroviral therapy with the triple drug regimen, then children with HIV basically disappeared. Today, we have eliminated neonatal HIV. It is eradicated. There is no excuse for HIV in pediatrics. The only excuse is when you have a healthcare system that fails to you. And that's the unfortunate situation for individual cases that you see here and here, people that arrive to labor without having been tested for HIV, because even if you receive anti-retroviral therapy around the time of delivery, the likelihood of decreasing HIV transmission drops quite dramatically, because one dose of anti-retroviral therapy cuts down transmission of HIV from mother to child by about 30%. One single dose. In 1990, I would have told a woman who showed up in my practice with HIV that her reproductive life was actually severely compromised. In fact, I would have said, don't even think about it. Why? Well, because your longevity is severely compromised. The likelihood of you transmitting HIV to your husband in the process of trying to become pregnant would be very problematic. And you have at least 30 to 50% chance of having a child that is going to be infected with HIV, a very bad scenario. And even if the child is not infected with HIV, the child is likely to suffer the premature loss of the mother. However, as of the year 2000, we changed policies based on the evidence. We now tell women infected with HIV, if you want to go ahead and plan for a normal family, feel free, go ahead, because you're going to have a near normal survival once you join the antiretroviral therapy program. Your reproductive life is going to be preserved. Your child is going to be born healthy, and you will be there to see your child through university. This is probably one of the most dramatic changes that I've seen in my life when it comes to medical developments, all during my professional life. I don't think it's going to happen again. Now, of course, you're going to say, well, you already eliminated transmission from mother to child, so that's no longer relevant. That job is already done. Is there any evidence that you can use HAART to stop HIV transmission in other contexts, say sexual transmission of HIV? And the answer is yes. I'm not going to show you all of the evidence. There is a very elegant meta-analysis that has been published. If anybody is interested, I'll be happy to provide you with a reference. It was published last year in the AIDS journal, and Attia, A-T-T-I-A, is the first author. But it's boring, it has no pretty figures. So I thought I'd show you this one, that at least we had color figures for. This one illustrates basically what we know. In cohorts of serodiscordant HIV couples, heterosexual couples, that is, in Spain, for example, it was shown that in the absence of therapy to the index member of the couple, that is to say, the member of the couple who is HIV positive, not taking treatment, you see frequent transmission of HIV over a given period of time. If the patient who is HIV infected is receiving single drug or dual drug therapy, basically you don't change that. And if you wonder why, it's because single and dual therapy have a very transient effect on viral load. It's trivial. It's very small. It has enough of an effect to have a limited effect on survival in the individual patient, but the viral load doesn't change enough to change where the patient is at with regards to the ability to transmit HIV. But once you treat people with HAART, during the period of time that this cohort was observed, there were no episodes of HIV transmission. I didn't say that it cannot happen, because statistically, the confidence intervals around this estimate include some transmission events that may occur. But the reality is that they are dramatically less than it would have been in the absence of treatment or with limited treatment, as in single or dual therapy. So, what about other cases? What about injection drug use? Can we stop it? Because that's pretty cruel kind of thing. I mean, you're sharing needles, you're sharing blood. Could we stop it there? And that was what it slowed us down. For a long, long time, we couldn't quite figure out how are we going to sort out this one. Because in heterosexual discordant couples, it's pretty easy. You ask somebody, who are you hanging around with, and you characterize what they're doing, when they're doing it, et cetera, viral load, and you can measure those things. But to be honest with you, IDUs, injection drug users, are a bit more promiscuous in their behavior. They share needles with you, with me, with the other one. And so it's a kind of a big network of people that they're sharing with. And so we couldn't figure out, how do we do this? How do we generate the evidence? Until my good friend and collaborator, Evan Wood, who works here at St. Paul's, came up with a brilliant idea. He said, well, why don't we stop looking at people and start looking at communities? So I'll explain to you this fairly simply. Over the last decade, we have been monitoring the events in the downtown east side, where, as you know, there are large numbers of injection drug users. Injection drug users in the downtown east side, they live next door to people who are HIV positive, people who are HIV negative. Sometimes they know, sometimes they don't know. So it's a bit like coming here, grabbing all of you. This is the downtown east side, and there is a chunk of you that are HIV positive, and there is a chunk of you that is HIV negative. And you're sharing with everybody. So if I try to figure out what is this person doing, that person or the other person, I go crazy. We can't figure it out. But if I take the whole community, and now I treat the community of HIV positive people and the community as HIV negative people as if they were two people, so to speak, then I make sense of what's going on. And that's what we did. So I show you here 10 years of virus load, the amount of virus in the blood of these people who are injection drug users in the downtown east side, but they are HIV positive. And what you see here is that, of course, to a large extent through treatment, treatment penetration in 1986 was less than about 5 or 6%, I forget now. And now at this point, it's in excess of 95%. So through treatment to a large extent, we drove virus load in this community down, 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 down. Now, this 6 number here means that this is equivalent to over 100,000 copies. This is down to undetectable levels. So basically, we have a very large range of viral load to start with, but it drops quickly to a median undetectable viral load, and it stays very low as a result of treatment. So the question is, did this correlate with changes in HIV new infections? We call that incidence of HIV in the community among those that were HIV negative to begin with. And the answer is in the red, and it says yes. What happens is that the virus load, the height of the viral load in the community viral load, drives the subsequent HIV transmission the following year, recognizing that we are measuring this on every year, right? And so what you see here is HIV entered this community in 1994, 95 type of thing. The virus load went up. We don't have those data because we were not yet set up to monitor this, but we know when the virus entered this community. So this is going up right here. The new infections are picking up, driven by the amount of virus in the community, And as the viral load goes down, so does the rate of new infections. Let me make one more comment. I didn't include the statistics. But one part of this that was fascinating to us is that when we looked at the statistical analysis, we found that while sharing needles in the community was associated with the risk of HIV transmission that was twice as greater for those that were sharing needles as a high-risk behavior, the virus load, as shown here, this kind of viral load was associated with 20-fold greater, right, I'm giving you the ranges, 20-fold greater likelihood of becoming HIV infected than people who were down here. So the hazard, the likelihood, the chances of a person becoming HIV infected was driven to a greater extent by the amount of virus that your cohabitating HIV-infected individuals had rather than the practice of sharing needles. All this time, we have been, and rightly so, don't get me wrong, I'm not trying that I'm going to encourage people to share needles, but all this time, we have been focusing on the sharing needles. Don't share needles. Don't share needles. When that's worth 2 points in the likelihood of contracting HIV, when we should have been concentrating on the lower your viral load, because that's worth 20 points on the scale, on the risk scale for contracting HIV. And that's basically what I'm telling you. If we drive the viral load undetectable in this community, you can go ahead and share needles. You won't get HIV. Oh, you're not getting. Didn't say that. Erase that. You're less likely. You're very unlikely to get HIV. You're going to get hepatitis C for sure. You're going to get a whole lot of other nasty stuff. But the point is that if we control HIV, the likelihood of transmitting HIV becomes a lot less significant. Of course, ideally, we would like people not to share and to have an undetectable viral load, because the undetectable viral load is good for them, for their health, but it's also good for decreasing transmission. So I'm sure some of you are wondering, why is he skipping over the men who have sex with men? Well, because we don't have the data. We don't have specific data for MSM because they fall somewhere in between the heterosexual couple and the IDUs in terms of the fact that they are sexual networks, and so it's more complicated to nail that particular thing. But let me say 2 things about that I think they are very relevant. Three things. First, the MSMs, men who have sex with men, they have the same response to treatment as anybody else. So their virus load in semen goes down just the same as mine or yours or anybody else. So that works biologically, no difference. The second thing is that there have been rectal mucosa studies where they take biopsies on rectal mucosa, and they show that as people become adequately treated, the virus in the rectal mucosa also goes down. So if the blood has no virus, if the rectal mucosa has no virus, and the semen has no virus, guess what's going to happen when MSM engage in unprotected sex if they have a undetectable viral load? Well, the risk for HIV is also going to be down. We haven't been able to prove it as such, but there is no reason, no biological reason to think that it's not going to be the same. Now, of course, because I don't have the data, I have a way to reassure you that this is the case. And the way to reassure you that this is the case is based on our experience between 1996 and 1999. Prior to that time, as you remember, we were using poor treatments that had no effect on HIV transmission sexually, as I told you before, or IDUs for that matter. And what you see here is that we had a stable rate of new HIV infections in British Columbia prior to 1996. When we started using highly active anti-retroviral therapy, the uptake was very brisk between 1996 and 1999. And while the uptake for anti-retroviral therapy went up like this, as I showed you in Richard Harrigan's earlier slide, you see that the number of new HIV cases dropped almost by about 50%. And guess what? Nothing happened after that. This remained perfectly flat. And the reason why it remained perfectly flat is because between 1999 and 2004, we took a bit of a wait-and-see approach with regards to antiretroviral therapy. We were focused only on trying to benefit individuals infected with HIV with treatment. And so we would say, well, how late can you start treatment so that you derive maximal benefit and none of the potential troubles associated with the old regimens that were cumbersome, they necessitated more pills, they had side effects, and so on and so forth. So now that all of that has changed, we are in a position to treat more people and better. I'll tell you more about it in a minute. But let's just concentrate on this figure. 50% decrease on HIV cases. Since our epidemic in BC is driven largely by MSMs, men who have men with sex, then I would use this evidence to say it also worked in MSMs. Now you're going to say, well, slow down. 1996, remember? 1996 was, for those of you that were in the city in that year, you'll remember the hoopla about the Vancouver conference, the TV, and the press, and all of the stuff. And there was a lot of messaging around the conference, including safer sex, and do this, and don't do that, and whatever. And so you're going to say, well, what about if all of that is the side effect of the knowledge dissemination that occurred during the conference regarding better sexual practices? And I'm going to say yes. Yes. That's why the syphilis rates went up since 1996 steadily. So, given that syphilis, and we didn't do this, we didn't plan it this way, this is the way it happened. So given that syphilis has gone up steadily, and in fact continues to go up as of this moment, and particularly so among MSM, and particularly so in the city of Vancouver, and incredibly so, a high rate of secondary syphilis, which means that people hang around with a lot of syphilis a lot of the time, a lot of unprotected sex, and so on and so forth. What this means is that a high-risk sex has not gone away, and yet it hasn't been able to change this curve overall. And the reason why that is because there is something that is putting pressure on HIV transmission that is unable to stop syphilis transmission. And I would argue that that's actually anti-retroviral therapy. So we're already seeing the benefit of anti-retroviral therapy on HIV transmission in our own community. And then this is what the ministry asked me. So wait a minute. All of this is very good, but what about the money? And you can't believe it, but this is one question after the other. So we went back to the drawing board, and we said, how are we going to figure out this thing? So we said, okay, well, if we have, this is the previous plot, we have evidence that there were approximately 800 cases per year. This is very back of the envelope, but just to give you a sense of what the numbers look like. So if we had approximately 800 cases per year prior to 1996 of new HIV infections, and then it dropped approximately to 400. This is 400 and change, but it's just to make the math simple. When we were asked to provide these numbers, 2005, we said, well, so in 2005, we have an HIV deficit in British Columbia of 400 cases. There are 400 cases that would have materialized if this continued, and every year here we saved ourselves 400 new infections. And so because we know that the minimum lifetime cost, therapeutic cost that is, for HIV is $250,000, and that's the minimum because estimates suggest that it could be as much as $1 million per person, particularly south of the border. So if you take this number, you can say, okay, well, if we save ourselves 400 cases and each one would have cost $250,000, you make the math here, and I'm told that this by that makes that $100 million. So you save yourself, averted a $100 million cost on treatment of HIV that did not materialize. The interesting part is that in the year 2005, that year alone, we treated approximately 4,000 people with antiretroviral therapy in BC for a total actual drug cost in that year of $50 million. So let me make that clear. We spent $50 million treating people who needed treatment so that they remain alive, remain active, remain out of hospital. That is called doing the right thing. We kept them going. That was cost effective. And that's the reason why the government was happy to pay for that treatment to take place. But in addition, on the so-called prevention axis, we save ourselves maybe up to $100 million down the road. So this investment that is cost effective here, treating people who are HIV infected, is actually generating savings in the other axis of $100 million down the road. In my mind, that's actually a very good investment, even during a recession. This is a cost-averting investment. We're saving money by treating people more effectively because they get better, they do well, they remain in the community, their children don't get HIV infected, but in fact, we're saving ourselves $100 million on new infection, treatment of new infections down the road. So I hope that so far I've been able to show you that highly active antiretroviral therapy is highly cost-effective. In fact, it's a life-saving strategy. It decreases mortality of people infected with HIV. It decreases morbidity or sickness among them. I didn't show you the data, but you can actually deduct fairly simply that health resource utilization is favorably affected when you increase treatment of people infected with HIV. And we know definitively that we have been able to virtually eliminate vertical transmission of HIV with treatment. Our new contribution to this discussion is to recognize that, furthermore, when the impact of HAART on HIV transmission is considered, HAART expansion, expanding the number of people, expanding the coverage with antiretroviral therapy, becomes a cost-averting strategy. And let me make it clear here, because at the end of the day, I'm actually a physician, I'm a doctor, I'm a treater. I did all of this because I wanted to justify a further investment on trying to bring treatment to the people who are not accessing treatment today, people in the downtown east side, people in Prince George, people in rural communities who are staying home and not coming forward for treatment because they don't know how to get here, or they don't have the means to come here, or they don't have they cannot make it a priority, they don't have the support to come here. And so in our traditional medical approach to these conditions, you sit at home, in the hospital, and you wait for people to come to you asking for the services. And what we've been trying to argue all along, in this rather convoluted way, is that treatment is good for the people who are infected and need treatment, but it's also good for society. Therefore, investing in additional $1 a day, because we've done the math, of outreach services to get to the downtown east side, Prince George, or people who have mental illness or so on and so forth, is actually worth your money. So as a taxpayer, you want to recommend that the government does that because it will save us money, let alone suffering and death, but it will save us money down the road, and we will have a better society as a result. Now, Bill Clinton got it. We convinced Bill by August 2008. So he went to the Wall Street Journal, and he said, until there is a vaccine, studies show that suppressing blood virus, and Julio Montaner, that's me. So that was great. We loved it. And we thought, well, now that Bill got it, and he's speaking publicly about it, everything is going to happen right away, but it took a little bit of time. Yet the economists got it, and they said, Julio Montaner, somewhere in here, we do it. So if Bill got it and the economists got it, you think we would have been done already, but not quite. It took until April 2009 when the Premier finally committed to this program, and I will give him kudos because he was the first politician in office, as opposed to former politician, that actually got it. And as a result of that, it is imminent that he will formalize the announcement for the expansion of antiretroviral therapy in the province of British Columbia. I am concerned, though, that people tend to become very simplistic on their approach to these matters. And so they may make the assumption that if we actually walk around the street throwing pills to the people, everything is going to be fine. And it doesn't quite work that way. Some of my friends here, they know what I'm talking about, because I throw them pills all the time. But the issue here is that we have a biomedical intervention, in this case is HAART, that works. I think I convinced you by now that it works for the individual who is infected and also for society at large preventing HIV transmission. But if we don't do a better job about testing people who don't know that are HIV infected, we cannot fix this baby. Because 25% of British Columbians that are infected with HIV are not aware that are HIV infected. And today, we have means to fix that. We have point-of-care testing. Is done in 1 minute. I could be testing all of you in the time that we took to listen to this discussion. It takes 1 minute per person. All I do is a poke in your finger, and within 1 minute, I can tell you this is your result. And yet we have not been able to embrace this new technology as part of our outreach campaigns to get people tested in their communities, bringing the testing to the people, as opposed to me sitting at home waiting for them to come and get me. Now, first, if we test them and we don't do anything to link them to care, we're not going to fix this. And linking to care may mean sometimes that we'll refer them to see Dr. Montaner at St. Paul's, 5th floor, and so on and so forth. But these people may not be in a position to do that. So we may have to bring care to the people. And that means that whether Mr. Harper likes it or not, we may need supervised injection sites and other such facilities that allow us to engage people where they are at to bring them into the healthcare continuum so that we can appropriately link them to care. And that's not only the problem. There are structural interventions, for example, that need to be revised. I'll be honest with you. St. Paul's is a smoke-free environment. So my crack users cannot come and see me here. And my smokers, some of them have a problem. Because if they have to wait for half an hour or something like that, they're just not going to work. St. Paul's has a policy that if you are acutely intoxicated, they're going to kick you out of the hospital. And guess what? I have a large proportion of my patients who don't know anything but acutely intoxicated. So we need to fix this. These are structural barriers. And I'm telling you about structural barriers in my own hospital, which has a very caring attitude towards people with this condition. So we need to fix the structural interventions. Well, imagine about discrimination, stigma, laws that criminalize HIV transmission. I mean, I could go on and on and on forever. So if we want to fix this baby, we need to change the attitude towards how we deal with this as a society. And that includes structural interventions, community interventions, and behavioral interventions that we need to pursue in more aggressive and sustained fashion. So the bottom line is that we have a way forward with regards to anti-retroviral therapy. It should help us to control AIDS, and we're convinced, as the economist has said now for the second time in 6 months, that this is the way forward. And look at me, I'm so happy there. This is after my suntan. I trust that I have given you a rather compelling argument that we can do a better job at not only treating people infected with HIV, but actually stopping HIV. And we can stop it if we actually make this a priority. Thank you.